record here in just a moment. I think our live stream is working. Yep, there it is. Perfect. Wonderful, wonderful, wonderful. All right, friends, welcome. We are here. We are live, and it's February, y'all. We are here for another Brunch and Learn brought to you by The Qualified, and we have an exciting and engaging time in store for you today. Those of us who are joining live from Zoom, welcome. Oh my goodness, we're so glad that you're here with us and you get to feel the momentum and move along with this conversation, along in this conversation with us. Those who are joining from YouTube and LinkedIn, we welcome you as well and thank you for tapping in and watching and getting this lovely information. Listen, just in case you don't know, the Qualified is here every month to help you and to help you stay qualified by offering you continuing education events just like this one, where we pull professionals from the health information and health informatics industry. We pull them and we get to spend some time with them as they unpack their wisdom and their expertise, and oftentimes take us along beautiful journeys of what they have discovered in their time or during their time in the industry. So this is good. We cover a wide range of topics, y'all, from coding to revenue cycle to data analytics, and the list just goes on. Whatever you need to stay up to date on your credentials, we're here to serve you. So not only do we offer continuing education events much like this one, if you are in the field of searching for a new credential or certification, we can assist you with that. If you are looking for some type of employment, perhaps you're ready to break into the health information space employment wise, and you're having a little bit of difficulty, well, we can serve you there as well. And on the other side of that, if you are an employer and you need some assistance finding qualified individuals, we want to help you. We want to fill your departments with those health information professionals who can do the job, who we back, who we stand up, and we support, right? So contact us at www.the-qualified.com. The-qualified.com. We're dropping that information in the chat for those who are in the chat with us, and other folks. Just feel free, visit our website so you can learn more about what we offer. Y'all, we're going to jump into this awesome conversation for today. My name is Dr. Japera Barnes, and I'll be serving as your host and moderator for this lovely morning. I want to take some time to introduce our speaker for today, because I believe she is going to enrich us in a very fresh way, y'all. So let me share a little bit of information with you about Miss Nicole Phillips. Listen, Nicole has been in the healthcare IT space for quite some time now, and her journey through healthcare IT is one that is representative of passion and persistence. She got her start as a hospital medical records clerk, y'all. And she fell in love with what we now call health information management. So she's been in this game for over 25 years. Specifically, she has been working at a company called Cantex, where she has grown from working in DME billing and skilled nursing facility revenue cycle. And now she's become the company's go-to expert on all things EHR. I know I'm throwing out all kinds of acronyms, right? But just follow with me, follow with me. Nicole has become Cantex's subject matter expert, especially during its early days of electronic claim submission and all of that. So her expertise has led her to spearhead multiple projects, several EHR implementations, and expand across, like I said, over a 25-year period. So Nicole has earned her master's degree. For those who need to know that, she is qualified, y'all. She's earned her master's degree in health information management from the College of Saint Scholastica. She became an RHIA, a Registered Health Information Administrator, and she became certified electronic health records specialist. She is maximizing those credentials and her experience in the field. Nicole is currently pursuing her doctorate in health informatics from Rutgers University. She's bringing both deep practical experience and cutting edge academic knowledge to today's discussion. And no doubt, this discussion is going to be rich. Help me welcome. I mean, put together your electronic hands, y'all, and help me welcome Miss Nicole Phillips to the qualified. Nicole, thank you for gracing us on today's Brunch and Learn. We turn it over to you, my friend.
My goodness, wow. Thank you so much for that warm and exciting welcome introduction. Greetings, everyone. My name is, as stated, Nicole Phillips, and I'm excited to discuss optimizing health information and technologies to improve workflows this morning with you all. To give you a little context, in continuation of the introduction, I fell in love with health information management back when it was called medical records. My journey in post-acute care began in the late 90s with Cantex Continuing Care Network, a company that's been around for nearly 50 years, and we provide services from skilled nursing and hospice to advanced primary care. We take care of the entire post-acute care journey. I've been with the organization through some pretty significant evolutions. Early on, I was that initial software resource for our AR department. Back when we were still using dial-up to submit Medicare claims, I spent a lot of time teaching myself the technical side of EDI 837 criteria, loops, and segments, and just fell in love with that whole process, which eventually helped us build the framework for our first Medicare Advantage submission in 2006. Since those early days of dial-up, I stayed busy. As stated, I earned my master's degree from the College of St. Scholastica in health information management. I earned my RIA credential and my certified electronic health records specialist credential. I love medical records. I love medical records as if you cannot tell. And currently I am working on my doctorate in health informatics from Rutgers. In my day-to-day role as Director of Applications and Analytics at Cantex, I manage 83 different applications, including 5 EHRs and all their moving parts. Most recently, my team and I tackled a major EHR implementation across 40 of our skilled nursing facilities in just 9 months. That experience really highlighted both the hurdles and challenges that happens with implementations. Upon completion of today's session, participants will demonstrate the ability to identify key workflow inefficiencies within their respective organizations, understand the major health information technologies available for workflow optimization, apply evidence-based implementation strategies derived from current literature and demonstrated through a real-world case study, and measure and sustain workflow improvements beyond our initial implementation. These objectives are intentionally designed to bridge the gap between informatics theory and clinical practice, providing health informatics professionals with immediate applicable knowledge and the tools to drive meaningful evidence-based change within their organizations. Today's agenda is structured across 4 segments. Each we're going to build progressively towards a comprehensive, actionable framework for healthcare workflow optimization. First is the foundation, which will establish our clinical and operational context. Next, we're going to do technology solutions. We're going to which represent the substantial core of our session today. We will conduct a structured, in-depth examination of 4 primary technology domains: EHR optimization strategies, workflow automation tools, including robotic process automation, clinical decision supports, and interoperability solutions. Implementation science will move us from the knowledge to actual application. And then we're going to do measurement and sustainability, which addresses what I consider the most frequently overlooked dimension of any technology initiative. We need to sustain and measure for long-term value. Your responses will enrich our discussion and ensure that the content remains grounded in our organization realities today. So let's get started with our first poll. We want you to put the answers in the chat. What is your biggest workflow challenge? A, duplicate documentation. B, poor system integration and interoperability. C, alert fatigue. D, manual data entry. Or E, communication breakdowns. Place your answer in the chat. Either drop the letter in there or a keyword. We can kind of see what your current workflow pain points are. We have C, alert fatigue. Yes, that's a big one. What else? Let's see. Angela, what are some of your pain points for your organization? Well, let's just touch upon alert fatigue because that represents one of the most clinically significant workflow challenges in the modern healthcare today, and one of the most frequently underestimated. You'll see as we continue our conversation today that the data is compelling. Clinicians override between 49 and 96% of clinical decision support alerts, which raises profound patient safety implications, which we will examine how thoughtful CDSS optimization can simultaneously reduce this alert burden and strengthen clinical safety outcomes. So let's get started. What I like to call the workflow crisis. Inefficient workflows does not just waste time, they compromise care quality and clinician well-being. For every hour of direct patient care, clinicians spend 2 hours on EHR tasks. Physicians dedicate only 27% of their day to direct patient care, while nearly half of their time goes to EHR and desk work, plus 1 or 2 hours of catch-up documentation each night. It's nearly the reverse of what we want healthcare to look like. 49% of providers represent burnout. The average clinician receives over 60 to 100 alerts per day and overrides 96% of them. This is a clear sign the system is working against them. And primary providers spend nearly 40% of their time looking at EHRs during the visit. Financially, poor interoperability alone costs the healthcare system an estimated $30 billion annually, and the downstream effects go even further. Medication errors, delayed care decisions, staff turnover, and dissatisfactions. Poor workflows don't create isolated problems. They create a cascade of compounding negative effects. But the good news is every single one of these challenges is addressable through a thoughtful technology optimization. And that's what we're here to discuss today. Now, let's talk about why organizations should invest in workflow optimization. And to do that, we need to speak the language of leadership. And that language is return on investment. Productivity gains are real and measurable. Organizations implementing comprehensive workflow optimization report a 42% average productivity enhancement, bed utilization improvements of 34.2%, so AI-driven capacity management, and overtime cost reductions of over 28% through these predictive analytics. Freed up clinical time is equivalent to adding a meaningful FTE capacity without even hiring a single new hire. We also see meaningful reduction in medication errors and adverse events. Research confirms that poor EHR workflow configurations directly contribute to errors that are frequently difficult to detect, making thoughtful design critical. From a financial perspective, preventing just one serious adverse event can justify a significant technology investment. From a quality perspective, the impact of patient outcomes can be transformative. A national sample study found that patients treated in hospitals with advanced EHRs cost 9.66% less per admission. That's not marginal, that's a compelling financial case. Now, when building the business case, ROI components falls in two categories, direct and indirect. Direct benefits are easy to quantify. You have time savings, which is labor cost reductions and increased capacity, reduce overtime, lower error costs. Direct benefits are equally important and even harder to quantify. Lower administrative friction correlates directly with improved satisfaction and reduced burnout of providers. Better retention means more experienced staff, which means better care. And when the EHR works for the clinicians, that clinician can focus on the patient and not the screen. It's a positive cycle that we want that builds on itself. The initiatives that get funded are the ones that bridge quantitative data with qualitative experience. Lead with these hard financial numbers, but don't stop there. The human ROI, reduced burnout, restored patient-provider relationships, long retention of your best clinical talent makes an argument that's very difficult for leadership to ignore. Now, we're moving into a technology deep dive as we talk about optimization strategies. So I want to emphasize this isn't about replacing your EHR. It's about making what you have work better. Starting with template optimization, role-based customization tailors each clinician interface to their specific scope of practice, eliminating irrelevant fields and reducing that cognitive burden. Smart defaults are pre-populated. Common values based on clinical patterns and context-aware fields dynamically adjust based on that patient's demographic, diagnosis, and visit type. And this ensures the right data is always accessible for that clinician. On documentation, smart phases and dot phrases expand abbreviated triggers into complete, standardized clinical templates, reducing documentation time while maintaining consistency. Auto-population pulls verified vitals and lab values directly into notes, and voice recognition enables natural dictation at the bedside, redirecting that clinician's focus from the keyboard to the patient. Order set optimization standardize excellence at the point of care. Evidence-based order sets translate clinical guidelines into actionable protocols, ensuring consistent access to validated care pathways, regardless of the provider's experience. Condition-specific order sets consolidate all recommended interventions into one streamlined workflow, eliminated the admission risk under time pressure. The result is both improved operational efficiency and elevated care quality. Finally, dashboard customization. Personalized workspaces surface role-specific data and eliminate that irrelevant content. Critical information must be immediately visible. Every unnecessary click increases cognitive load. When providers have to navigate multiple screens to look for the information they need constantly, that EHR becomes an obstacle for them. That's a measurable workforce failure, and it's entirely preventable. The EHR must be architected around the clinical workflows and not the reverse. Workflow Automation is revolutionizing healthcare operations right now. Let's walk through 3 areas where it's making the most impact. Robotic process automation. Now, think of RPA as a software robot designed to handle repetitive rule-based tasks, and that impact is relevant at every level of HIM practice. The benefits are well documented. In claims processing, RPAs can verify coding, they can check for errors, they can even submit claims, reducing processing time by up to 80%. Prior authorizations that currently consume hours of staff time can be automated for straightforward cases, accelerating that turnaround without sacrificing accuracy. Insurance verification is another one. It can run automatically overnight with an RPA bot because RPA bots don't observe office hours. And critically, RPA, they don't get tired, they don't make transcription errors, and they don't cut corners at the end of a long shift. Perhaps most importantly, automation frees your team to focus on what work that actually requires human judgment, that complex authorization, that patient problem resolution, and situations where experience and critical thinking matters the most. For those of you early in your HIM careers, APA touches those daily functions you're building skills in right now. For those in those middle and senior roles, the strategic question becomes, what processes in your organizations are strong candidates for automation, and who is leading that conversation? This isn't purely theoretical, as our organization currently has numerous RPAs in active planning and in operation. Automated notification systems go well beyond convenience. This clinical and operational stakes are very significant. One landmark study documented a cardiac arrest event dropping from 14 to 2 following the implementation of automated notification system with an accompanying decline in overall mortality. That's not an incremental improvement. That's a patient safety transformation driven by this smart communication infrastructure. The day-to-day applications reflect the same principle. Critical labs can be sent immediately to the right provider's phone, not routed through a unit clerk, not sitting in an inbox, not discovered hours later. Automated appointment reminders reduce no-shows by 30%, representing both meaningful revenue protection and improved patient access. Automated refill notifications reduce unnecessary calls to clinical staff while improving that medication adherence. That's very important. But technology alone is not sufficient. The defining factor in intelligent routing, getting that right message to the right person through the right channel at the right time. A critical alert sent to the wrong provider through a channel that don't have a monitor is no better than no alert at all. So it's very important that thoughtful system design is what converts automation into outcomes. And then we have intelligent routing and task assignments. This is where AI enters the picture. A 22-month hospital-based study found that the urgency and task type were factored into routing logic. Urgent tasks were accepted and completed significantly faster, a finding that with direct implications for both patient safety and operational efficiency. AI-enabled systems can simultaneously analyze task complexity, current workflow, and individual expertise, routing work to the right person at the right moment. Whether they're relying on a charge nurse to manually triage and delegate, the system handles that cognitive work automatically and continuously. The governing principle is simple and worth carrying through the rest of our session today. Automate what can be automated and elevate what requires human expertise. AI handles the sorting, the sequencing, and the routing, but your people handle the judgment, the complexity, and most importantly, the care. Clinical Decision support can be your best ally or your biggest obstacle, and the difference comes down entirely down to how it's implemented. Oh, excuse me. We touched on alert fatigue earlier, but it bears repeating because the numbers are striking. Clinicians receive between 60 and 100 alerts daily and override anywhere from 49 to 90% of them. That's not a minor inconvenience. That's a system failure with real patient safety consequences. And that was one of the pain points that was listed in our first poll. That's once providers learn to ignore alerts habitually, it's only a matter of time before a critical one gets dismissed along with the rest. The technology designed to protect patients ends up working against them. This happens by poor design. Alerts fire for drug interactions involving medications the patient isn't taking. They appear after an order is already placed rather than during the ordering process when they could actually influence a decision. Everything gets flagged as urgent, so nothing feels urgent anymore. The good news is that every one of these problems is addressable. Tiered alerts are a strong starting point to address. Not everything is critical, and your alert system should reflect that. Critical alerts require a hard stop. Warnings are important, but it allows the provider to acknowledge and continue. Informational alerts are contextual. They're low friction, good to know. This structure alone can dramatically reduce override rates by restoring meaning to the alerts that actually matter. Beyond tiering, alerts should fire based on patient-specific clinical context, not blanket population thresholds. Alert parameters should be grounded in clinical evidence, not set arbitrarily during implementation and never revisited again. Different roles need different decision support. So routing the right alerts to the right clinician reduces noise and it increases relevance. And override rates should be monitored monthly. A high rate is always a signal worth investigating. Well-optimized CDSS goes well beyond basic alerting. Modern systems offer predictive analytics that enable early clinical intervention, such as sepsis detection algorithms with demonstrated mortality reduction. There's risk readmission scoring, comprehensive drug interaction checking, and evidence-based clinical pathway guidance. The goal is straightforward, but the execution requires intention. Deliver the right information to the right person at the right time. Every redundant alert, every irrelevant notification, every poorly timed warning is just noise to the clinician. And in healthcare, noise has consequences. Now let's talk about interoperability, which may be the single most critical enabler of workflow optimization, and poor interoperability is the root cause of many of the workflow problems we discussed earlier in our session. You can implement every tool and strategy we covered today, but without a solid interoperability foundation, you're building on sinking sand. A study revealed the following 6 outcomes for poor interoperability. Patient safety events were associated with increased medication errors and misdiagnosis. Medication safety influenced by interoperability. Data accuracy and errors based on fragmented systems produce measurable data accuracy problems in clinical areas. Productivity improvements in time and savings in clinical workflows for interoperability were missed and inconsistent, highlighting that implementation quality matters. Cost savings was associated with reduced costs, though true effect sizes were difficult to isolate. And care effectiveness found that poor interoperability directly impedes care, coordination, and clinical decision supports. Now, FHIR, Fast Healthcare Interoperability Resources, represents today as the 21st Century Cures Act in the US mandates that our EHR vendors are legally required to support for API process access for their patients' data. Unlike the older HL7 standards that many of us are familiar with in HIM, FHIR uses a modern web-based technology and RESTful APIs that today's developers are already fluent in. That familiarity matters. It makes implementation significantly faster, less expensive, and more sustainable than our legacy integration approaches. Organizations transitioning from legacy HL7 to FHIR has seen a 60% decrease in time required to onboard and integrate new clinical applications. And also, nearly 70% of organizations using FHIR report measurable improvements in both cost reduction and care outcomes. The real world use cases are broad and directly relevant to HIM practice at every level. Patient data exchanges between providers, care coordination across the continuum of care, population health analytics that aggregate data from multiple sources, and research data sharing that maintains appropriate privacy protections. For entry-level professionals, understanding FHIR is increasingly a baseline expectation. For senior leaders, it's a strategic infrastructure decision with long-term organizational implications. Now let's talk about HIE, or Health Information Exchange. This takes interoperability from a technical concept to a clinical reality. HIEs allows organizations to share patient data across our institutional boundaries, and the impact of care quality can be immediate and profound. Consider a patient that arrives in the emergency department unable to communicate their medical history. With HIE in place, the care team has access to the patient's records from other providers, their medication, their allergies, their prior diagnosis, their recent labs. This is just not operationally convenient. In the right circumstances, it's life-saving. It can also reduce duplicate testing and protects patients from unnecessary procedures and reduce costs across our healthcare system. Now, while the technical specifications of FHIR are impressive, the real value of interoperability is measured in human impact as well. As I experienced this firsthand in 2025, when my mother suffered a major medical event that resulted in a 3-month journey across 4 different facilities and 3 separate healthcare organizations. Now, as a daughter, I'm living in another state, and that potential for this fragmented care was a constant source of anxiety. However, because of the robust HIE that these organizations participated in and we're discussing today, her records were shared seamlessly at every transition of care. And that seamless exchange did more than just move data. It built confidence. It gave me the peace of mind that regardless of which facility she was in, her providers and clinicians held her complete health picture at their hands. And this is the ultimate goal of our work, ensuring that the right information follows the patient so that families can focus on healing rather than tracking down missing charts for their loved ones. For HIM professionals, HIE sits squarely at the intersection of data governance, privacy, and care quality, which is precisely where our expertise is most valuable as HIM professionals. Now, API integration. In my role as a director of application, my team and I, we have a non-negotiable standard when reevaluating any new technology. How can we API to this software, or at minimum SFTP to it? This isn't just a technical preference, it's a strategic requirement for safety and efficiency to connect these different disparate health systems. Modern APIs are what makes seamless connectivity between health systems possible in practice. Real-time data flows between the EHR, the laboratory, the pharmacy, the imaging system to reduce and eliminate manual data entry and virtually erases such things as transcription errors and ensuring that the right information is available at the point of care without requiring a staff member to manually bridge that gap. The bottom line is this. Without strong interoperability, you will continue to see duplicate documentation, communication breakdowns, and manual workarounds that exhaust your staff and compromise your data. With it, you'll create the foundation on which every optimization we've discussed today can actually succeed. Interoperability isn't just an IT problem, it's an HIM problem. And that means it's our opportunity to lead this charge. Now, let's pause for another check-in after we check our major technology areas. Which technology area would provide the most immediate value in your organization? A, EHR optimization. B, workflow optimization. C, clinical decision support. Or D, interoperability solutions. Drop your answer in the chat. A, B, C, or D? I see B, workflow optimization. B, Julia saying workflow automation. Automation typically delivers the highest ROI for those mundane administrative tasks, such as claims processing and prior authorization, insurance verification. These are really high volume, rule-based functions that are strong candidates for automation and where the time and cost savings are the easiest to quantify for leadership. Here's the good news for all of these points, though. These are not competing priorities. They actually could complement each other. The most successful organizations don't just choose one and ignore the rest. They use a phased approach, starting with quick wins that build credibility and momentum, and then layering in more complex integrations as organizational capacity grows. Now, with that context in mind, let's move into our session today that brings this all together. How to actually implement these solutions successfully in your own organizations. Successful implementation requires a structured approach. And this is where most organizations rush. The ones that get it right are the ones that resist the urge and do this foundational work first. Phase one is assess. Before you touch a single system, really understand what your current state workflows are. Shadow clinicians, you want to interview your staff at every level. Observe the actual work patterns because what people say they do and what they actually do are two very different things sometimes. You want to look for specifically for duplicate work, broken handoffs, and those nasty workarounds, because workarounds are almost always a sign that the workflow has quietly adapted around a system that isn't serving any longer. Then establish those important baseline metrics before anything changes. You want to document either time, error rates, or denial rates. Because remember, you cannot measure improvement without a baseline, and you cannot build a business case without data. Phase two, let's define your future state and be real specific. Select technologies that address your identified pain points. Let your assessment drive your technology decisions and not the other way around. You want to build a business case that captures both your hard ROI and qualitative outcomes like retention and burnout reduction. And assemble a cross-functional team from the beginning. Clinicians, you want your IT, you want operations, and your frontline staff. Remember, implementations that are IT driven without meaningful clinical input will consistently struggle at go live because clinical buy-in is not a nice to have, it is a prerequisite and very, very important. Phase 3 is implement. Use a rollout that's phased. In our most recent 40 site rollout, we piloted one site first and then we expanded in waves. And every wave taught us something the previous one had not. Invest in training more than you think you need to. It's consistently the most underfunded and overlooked component of healthcare technology implementations. And to develop those very important super users, frontline staff who receive deeper training and become those local experts on the ground. When a colleague is struggling at 2 p.m. on a go live day, they're far more likely to turn to that trusted coworker than submit a help desk ticket. So you want to build that support structure intentionally. And lastly, phase 4, optimize. Remember, go live is not the finish line. It's only the starting line because you need to measure outcomes against your phase 1 baseline. Gather that ongoing feedback systematically. And when one department develops a workflow that works exceptionally well, spread it, share it. Cross-site learning accelerates improvement for everyone in your organization. This 4-phase framework is scalable, whether you're implementing across 40 sites or optimizing one single department. Assess thoroughly, plan deliberately, implement carefully, and optimize continuously. The organizations that follow this approach don't just go live successfully, they build the institutional capacity to keep improving long after the project team has moved on. So, excuse me. So now let's look at a real world example of alert optimization done right. Vanderbilt University BPA ClickBusters program. It's one of the most creative and replicable approaches in the literature in regards to alert fatigue. Like most healthcare systems, Vanderbilt was dealing with significant alert fatigue. Their EHR was generating a high volume of best practice advisories, or BPAs, that were interrupting the clinical workflows at an increasing rate. And the inevitable result was that more and more of them were being ignored. In 2020, the Vanderbilt Clinical Informatics Center launched ClickBusters, and what made it genuinely innovative wasn't that it wasn't technology, it was the approach. Rather than having IT staff the pharmacists were invited to review and improve these alerts themselves. The people closest to the problem was given ownership of the solution. The process was systematic. Volunteers followed a standardized 10-step review for each alert, examining the clinical logic, analyzing real-world override rates, and making one of the 3 recommendations to discontinue it, to modify it, or confirm if it was already optimal. All the changes went through the normal clinical governance before implementation, ensuring the reducing burden never came at the expense of patient safety. But to drive participation, they gamified the entire process. The volunteers earned scores and prizes based on their measurable impact on the alert reduction. That combination turned what could have been a tedious committee exercise into something people actually wanted to be a part of. And the results were striking. Across 2 3-month rounds, participants reviewed 84 alerts covering 20% of Vanderbilt's role-based advisories, resulting in reducing 71,227 fewer interrupted alerts firing each week. This was 15% reduction system-wide. 10 alerts were completely turned off, 42 were modified, and 32 were confirmed as functioning optimally, and they didn't change. So this was a reminder that not every alert needed to be fixed. Several lessons from this study can translate directly to our organizations. Frontline engagement is a non-negotiable. Practical clinical wisdom cannot be replicated by IT staff reviewing logic tables in isolation. That gamification actually works. Recognition, motivated, sustained participation that a simple mandate could never achieve, possibly never achieve. A systematic approach produces consistent, credible outcomes, and governance oversight keeps patient safety central. What makes ClicksBuster particularly valuable is the replicability. You don't need a proprietary technology or a large dedicated team. You just need engaged clinicians, a structured approach, and the willingness to trust frontline staff with meaningful work. And this alert optimization is not fundamentally a technology problem. It's a people problem and a process problem. And when you engage the right people in the right process, the technology follows. Here's something that no vendor would tell you in their sales presentation about technology implementation, successes and fails. It based on change management. The technology is really the problem. The people side almost always is, and it deserves just as much planning and investment as the technical side. Executive sponsorship is non-negotiable in change management, and permission is not the same as sponsorship. You need leaders who will show up at Go Live, who will send communication themselves, who will ask about implementation progress in the operational meetings. When the frontline staff sees the senior leadership genuinely investment, this signals to them that this initiative really matters. And that signal is worth more than any training module. Involve frontline staff from the beginning, not as a courtesy, because their insights will present mistakes no project team can catch later on from a conference room. It also creates ownership, and the people who help shape the solution are far less likely to undermine it at Go Live. Super user programs are one of the most highest return investments in this process. Communication needs to be ongoing, and multi-channel, and relentless focus on the why this matters for patient care, why now, why this approach. And when things don't go as planned, and they won't always, acknowledge it openly, be transparent. This transparency builds more trust than a smooth rollout ever could. Training is consistently underfunded in healthcare technology implementations, and that cost shows up at Go Live. Invest more than you think you need to. Role-based training, hands-on practice before Go Live, and at the elbow support during the Go Live. Those first critical weeks made a measurable difference in adoption rates and error volumes. And then finally, expect resistance and plan for it. When a clinician says, this is going to slow me down, don't argue. Just show them the data from how it won't, because evidence is far more persuasive than reassurance. Because people don't resist change, they resist being changed. When you involve the people in the process and demonstrate clearly that this change serves the needs for themselves as providers and the patients, resistance transforms into engagement. So get change management right, and your technology will succeed. Now, it's been said before, and it bears repeating, you cannot improve what you don't measure. But measurement is only valuable when you're tracking the right things in the right way and starting at the right time. 4 categories of metrics matter the most. Efficiency metrics are the most visible to the people doing the work every day. Documentation time per encounter is a primary indicator. If clinicians are spending more time documenting after implementation than before, then something needs to be addressed, regardless of what else is going on or going well. Task completion times, the system response times, are incremental friction that can all compound across the shift that could result in meaningful productivity losses to providers. Quality metrics are what connect the workflow optimization to the patient outcome, and what gives you an initial clinical legitimacy beyond the operational story that you want to tell. The medication error rates, the protocol adherence, documentation completeness, and patient safety events are measures that demonstrate whether optimization is delivering on its core promise. Now, for HIM professionals specifically, documentation quality is squarely in our domain and an area where we can provide unique leadership in measurement design and ongoing monitoring. Financial metrics are the language of leadership, and precision matters here. Vague claims don't move the decision makers in the C-suite. Specific, quantified outcomes do. Don't say we save money on lab orders. Be specific. Say we reduce duplicate lab orders by 30%, resulting in $1 million in annual savings. Express productivity and gains in FTE equivalents. This translates time savings into safe staffing capacity terms, and that makes value more concrete and immediately understandable with your leadership. Satisfaction metrics complete the picture in a way that financial quality data alone cannot. Clinician satisfaction, staff engagement, patient experience scores, and retention rates are all leading indicators that often signal problems before those problems show up in operational data. When strong performers start leaving at higher than normal rates, it's rarely a coincidence. So establish your baselines before your implementation begins. You must have the before picture to credibly tell your after story. And track continuously so that emerging problems surface early when they're still correctable. Now, implementation is just the beginning. Going live is actually the easier half of the work. The real challenge and the real measure of organization maturity is sustaining those improvements over months and years as the staff turns over, as priorities shift, and as technology continues to evolve. Research confirms what experienced implementers already know. A systematic review of evaluating hospital-wide improvements at an average at 4 years post-implementation found that sustained improvement is not easily achieved, and that organizations who sustain it do so through 3 identifiable themes: people, process, and organization. That framework maps closely to what we've learned through our own experiences. And here's how high performing organizations build sustainability from day one. Governance structure sustainment optimizes requires sustained oversight. And that means a formal governance structure with real authority, not just advisory status. Establish a workflow optimization committee with cross-functional representation. You want to have clinicians, IT, operations, quality, even finance, all need a seat at the table. Meet monthly during the first year, and then you can transition to quarterly as your implementation matures. This critical distinction is decision-making authority. A committee can only recommend but cannot act. If you who cannot act will lose credibility very quickly. So give this group the authority to make meaningful decisions backed by visible executive sponsorship that signal that this work matters in the long term. Optimized workflows don't stay optimized on their own. Without active stewardship, drift happens. People will revert to their familiar habits. Those nasty workarounds quietly will reappear, and gains will erode gradually. Conduct quarterly workflow audits to assess whether optimized workflows are actually still being used. And then those annual comprehensive reviews provide a broader lens. Are those workflows still aligned with organizational needs, which change even when technology doesn't? Monitor those dashboards continuously. Conduct semi-annual user feedback surveys to see if there are some issues that have surfaced. The goal, remember, is always to be proactive than to be reactive. And training doesn't end at go live. Treat it as if it does is one of the most common and costly mistakes in healthcare technology management. Every new hire needs a comprehensive onboarding that reflects your current workflows and best practices. Don't assume they'll learn organically from colleagues, because those colleagues may have drifted from your optimized state in ways invisible to a supervisor, but could be obvious at bedside. Refresher training for existing users catches those drifts before it compounds, and advanced training for power users or super users ensures your most capable staff are continuously maximizing what the system can do. Your frontline staff knows where that friction lives, but only if you build systems that make it easy and safe for them to tell you. Anonymous suggestions could be a mechanism to remove those social barriers of reporting concerns. Your department level champions serve as day-to-day liaisons who can identify patterns that no dashboard would ever catch. But most critically, close the loop on every piece of feedback quickly. When people stop reporting problems to you, it doesn't mean the problem has gone away. It means the people have stopped believing that anyone is listening. And once that trust is lost, it's very difficult to rebuild. And they can revert back to those nasty workarounds. Stay current with system upgrades and actively evaluate new features with every in each release. They may address pain points that existed at your original implementation but went unresolved. Also, pilot those emerging capabilities like AI-powered documentation in control environments before the broader rollout. And remember to sunset those tools that no longer serve a purpose. When one department develops a workflow that dramatically reduces documentation time, other departments should know about it and have a clear pathway to adapt it. So build an internal best practice library, participate and present and attend professional conferences like AHIMA and HIMSS are great opportunities to learn from your peers and build your organizational professional reputation at the same time. Publish those success stories when you can, and reinforce internal commitment and build those external credibility that supports recruitment, partnership, and future funding. The governing theme is straightforward. Sustainability is not an outcome you achieve. It's a discipline you have to practice. Well-coordinated change delivery, customized local integration, and continued change efforts are the three elements that separate organizations that sustain improvement from those that don't. Now, before we close, let's do one last check-in. This one is about you and your organization specifically, where you actually are right now, not where you like to be. Are you A, ready to start immediately? B, need executive buy-in first? C, need to assess current state first? D, need additional resources, budget? E, not sure where to begin. Throw your answers in the chat. I see D a couple of times, need additional resources. So let me leave you with a few takeaways from today. And these five concrete action items you can act on this week. First, the workflow crisis is real and is urgent and is costing us money in every direction that matters. For-profit technology solutions are available to you right now, not someday, but today. EHR optimization through smart templates, streamlined notes, evidence-based order sets, role-specific dashboards designed around how people actually work and not how the system was originally configured. The ROI is significant, measurable, and entirely presentable to leadership. We're talking about 42% potential productivity improvements. These are not incremental gains, but transformative dollars, meaningful reductions in medication errors that save both lives and dollars. Successful implementations require structure and not speed. Follow that four-phase framework: assess, plan, implement, optimize, and resist the pressure to shortcut the assessment phase. The time you invest in understanding current state workflows, identifying real pain points, and establishing honest baselines is not time lost. Fifth, change management is not a component of implementation. It is the foundation of it. And this cannot be IT driven alone. It must be led by clinical leadership with frontline staff and involved from the very, very first conversation. So your first action items for this week to think about: assess your biggest workflow pains this week. Identify one quick win. Begin building your business case. Engage your key stakeholders early. Start small, measure everything, and scale what works. You came into today's session with real challenges. You're leaving with proven frameworks, evidence-based strategies, real-world examples, and a clear picture where you can start. The knowledge is yours. The frameworks are yours. The next move is yours. Now go transform your workflows, and in doing so, transform the experience of the patients and the clinicians who depend on us to get this right. Thank you for your time today. I'm Nicole Phillips. Reach out to me on LinkedIn. Let's connect. If you like a copy of my references, send me a message on LinkedIn, and I'll be glad to share them all with you.
Perfect. Thank you so much, Nicole. That was a great, informative, and really, really deep dive into improving workflows and optimization, just as the title demonstrated. So thank you so very much for sharing that information with us. Wow. We usually save time for questions, and I'm happy to, if there are any questions. I know we still have a couple of guests, and we're right at time. So if you have to drop off, that's okay. I totally understand. But if anybody has any questions for Nicole, then please feel free to post those in the chat, because we can continue the conversation at least for a little bit longer. We got a couple minutes, don't we, Nicole?
Absolutely,
A
absolutely.
couple of minutes to ask some questions up in here. I have a question, Nicole, because this is just, I love the content that you provided to us today. It was very practical, very very good, because these are real experiences that people encounter and things that we have to work on as health information professionals. I'm just so curious. Out of all of the time, the years that you have spent in this industry, in this space, can you share with us a time where a workflow implementation or change went way wrong for you?
And I'll tell you, it's because of failure of communication.
Hmm.
You cannot work on a silo. You cannot execute in a silo. You have to make sure you communicate and engage all those stakeholders. You have to listen to their pain points, get their input into it. And then you have to, for sometimes, well, because just because what you think the vision is for that optimization is not going to work. You got to engage those frontline clinicians. They're the one who I could call, they're in the trenches. So they know. So the biggest failure in a rollout, optimization rollout, it was failure to communicate, failure to really listen, failure to understand their pain points.
Oh, wow, wow, wow. And with all, because I imagine that that happens a lot
Mhm.
for people, right? And it could be a little bit, demotivating or something. Because that's a huge, when you run into those types of problems, sometimes people might get thrown off by it. That's what I'm saying. Like it could be,
Mhm.
a lot of pushback. People can get thrown off by that. But what did you do in that time, or even just over the span of your time in this space? What do you do to stay motivated? You overcome those challenges, but what keeps you going and keeps you motivated in this career field?
Well, like I said earlier, I love medical records. I love the smell of it. Back when we had the paper charts in the big medical records rooms, and then
Yeah.
when we shifted to electronic medical records, I love the process of it all. So that would be my biggest motivator. And then on top of that, I'm passionate about making efficiency and making things work easier for those clinicians, because I I embrace health information management because I cannot do that direct patient care, but I
Yeah.
feel empowered to make it easier for those that can, so they can take care of those patients in the best way possible, in the easiest and most efficient way possible. So that is
I
my
love
biggest
that.
motivator.
I
Mhm.
love that. I love that. That's your driving force. That's what keeps you going. Perfect. Listen, Nicole, we're going to be in touch. Absolutely love this conversation today and what you shared with us. And so, for those who are still watching, either live on LinkedIn or live on YouTube or still in the call with us, thank you so much for taking the time to tap into this month's Brunch and Learn brought to you by the Qualified. We will be back again in March, y'all. In March, we'll be back, same time, same place. To learn more about what we have going on, visit www.the-qualified.com. Subscribe to our website, our news feed, our newsletter, and other things that may be going on so you can stay up to date. So you don't miss out on beautiful opportunities like this to keep your education going, to get new credentials, to learn about what's happening in the industry, and so much more. It's been my esteemed pleasure to join you today, and I hope to see you all in March. Until then, continue to shine bright and stay wealthy in every way, everybody. We'll see you next time. Bye.
Bye bye.